The third thing we should be looking at is raising the age of eligibility, looking at that very seriously and incorporating that into the program.
You are listening to CEO Perspectives, a podcast by the Conference Board.
Welcome to this episode of CEO Perspectives, a signature series by the Conference Board. CEO Perspectives are conversations that take an objective, nonpartisan look at a range of subjects that matter most to business leaders. I'm Steve Odland from the Conference Board, the host of this series, and in today's conversation, we're going to discuss Medicare. What is it? How can we improve it? And where do we take it from here? Joining me today is Lori Esposito Murray, the president of the Committee for Economic Development, which is the public policy center of the Conference Board. Welcome, Lori.
Hi, Steve. How are you? Thanks for having me.
Thank you. Well, we're talking today about Medicare, but before we do that, let's just make the distinction between Medicare and Medicaid. What is Medicaid first, and then what is Medicare?
Okay, Steve. So Medicaid is a government health insurance program for adults and children who have limited resources. Medicare is a government health insurance program for seniors over 65 and for some younger with certain disabilities.
Got it. Okay, so I think that's helpful. So we're going to focus on Medicare because this is the big kahuna in the federal budget. But let's just do a little history lesson here. When was Medicare implemented? What were its original goals? And then how have those goals changed over time?
So Medicare was implemented in 1965, but it was actually on the national agenda since 1945 with Harry Truman. And the reason why I'm mentioning that, because when President Johnson signed the bill that enacted Medicare, he actually went to go visit Harry Truman and signed it with Harry Truman in Missouri. And Harry Truman was the first person to actually become the first Medicare enrollee. And so the point of Medicare was to actually address the problem of healthcare, health insurance for seniors over 65, which was a very vulnerable group during the Depression, which is actually what raised Harry Truman's awareness of the problem. A lot of the elderly were very dependent at the time on their children for support, and their children during the Depression were out of jobs. And so that's what put it on the national agenda. And President Johnson signed it into law in 1965. Its original goal was basically hospital insurance, but also physician care then joined into the original Medicare program that it encompassed. And what we've seen over time is that the benefits and what the coverage has expanded and expanded.
Yeah, and so this is a huge change. I mean, actually, healthcare insurance wasn't really popular or widely used back when Medicare was implemented, but it was more out of a need for the country to, take care of its seniors, essentially, when they got out of the workplace and so forth. Now it's gotten a little more complex. There are parts A, B, C, and D, and all you have to do is listen to the ads on TV to know that it's complex. Can you just give us a little bit of the ABCs on parts A, B, C, and D?
Okay, so parts A and B were basically the original parts. Part A is the hospital outpatient care, the inpatient care, and Part B, sorry to be confused myself here, and Part B is the outpatient care, the physician care. Part D is your prescription drug coverage. And then Part C, which came into play starting in 1997, is Medicare Advantage, which provides seniors with alternatives to choose health insurance providers through Medicare Advantage. So it's an alternative to the original Medicare program because you have the alternative of your health insurance providers through HMOs, for example.
Okay, so A is hospitalization, B is doctor care, D is drug. That one's easy to remember, and C is Medicare Advantage, which is the supplement. It's the private part. So which parts are government funded and then which parts are privately funded?
Okay, so it's a bit of a mix here. And basically, the clearest part is Part A. So the hospital care is paid through the payroll taxes that everyone pays as part of their wages when they're in the workforce. And so that one is pretty clear. That's where the hospital care, inpatient care is paid for. Then you have basically the other programs, particularly the physician and the drug coverage. You have general revenues. That's from other taxes, which pays for about 40% of Medicare now. You have basically the premiums that you pay as an individual, the premiums you pay, then also pay for the coverage in Part D and Part C. So those are the main areas where it's basically payroll taxes, general revenue, which includes income taxes, and then you have premiums that also pay for Medicare.
Okay, so A and B are, you think of it as government funded or payroll tax funded, and C and D are private, right?
Right.
Okay, so and that's important because the federal budget deficit is exploding, and a large part of that are Medicare expenses, which are parts A and B. So maybe give us a little hit. When it was first set out, it was intended to be a relatively small portion of the budget, and now it's quite a bit bigger. Give us some comparisons on the size.
Okay, so what's interesting is that in the debates in the 1940s and 50s, the discussion was whether you are going to have a national healthcare system or you're going to have a healthcare system for seniors. And it really did rein it in. It became a healthcare program for seniors. Today, what we're seeing, what's happening with the Medicare program costs is in fiscal year 2023, it's about 12% of the total federal government spending. That's about 3.8% of GDP. And in 10 years, it's expected to become 6% of GDP. So those are huge outgrowth in the expense of Medicare. Two main reasons. Our population is getting older. And the other reason is the rising cost. And so those two combined are really going to affect the cost of healthcare, and Medicare is one of the main drivers of that.
Yeah, and it just keeps growing, Lori, as a percentage of the federal budget. Why does that happen? I mean, is that just simply inflation?
It's in part inflation. It's in part the cost of healthcare rising, and that's due to inefficiencies. That's due to how the program structured, as some analysts say, that it's the structure of the program that's actually causing it to be more costly, and it could be reconfigured to be more competitive. That's one of the main positions, as you know, that the Committee for Economic Development has been promoting, that we look at more competitive systems to bring the costs down. But we're dealing with an aging population, and you're going to have more seniors enrolling into Medicare in the next 15 years than children are born in the United States.
Yeah, and if there was ever any incentive to keep working, it's the the albatross of trying to figure out Medicare and what would happen when you stop working. I mean, I don't think I'm ever going to stop because I can't figure this thing out. Anyway, that's a separate issue. This whole thing is though continuing to eat more and more of our resources. As you said, it was originally intended to just be a tiny portion of the budget, but due to the aging, due to inflation, and the cost of prescription drugs, which continue to go up, and these more and more expensive treatments, man, where do you see this thing leveling out, or does it never level out?
So it has to level out, Steve. We really have to rein in our spending on healthcare, and Medicare is a critical part of that spending, a real driver of our national debt. It has to be reined in. The demographics aren't working. The cost is inflating. We have to rein it in for our fiscal health going forward, for the stability of our economy, for our continuing ability to prosper, and for our economy to grow. So it is, as I mentioned, one of the main drivers of fiscal instability or ill health.
Yeah, and so it has to, but do you have any forecasts on what percentage of GDP or what percentage of the budget is going to, it's going to consume before it does level out?
Well, in terms of GDP, in the next 10 years, it's almost going to double. It's going to go from 3.8%, just under 4%, to over 6%. That's in 10 years, Steve. We're not looking at a 30-year projection here. We're looking at a 10-year projection here.
Yeah, and you still have so many baby boomers retiring every day, entering that portion of use. It's just incredible. So what do we do, Lori? Because this is consuming more and more of the budget. It's crowding out other priorities for spending, and it's been described as the third rail of politics, meaning nobody wants to cut it, or nobody wants to amend it, or fix it, because they don't want to disappoint seniors. But what do we do?
So one of the opportunities in this dark cloud is the fact that the Medicare's hospital insurance fund, its trust fund, is actually going to reach insolvency in 2031. So that should be putting it, or it gives leverage to put it on the congressional agenda, because if nothing is done, you're going to be looking at mandatory spending cuts beginning at about 11% in 2031 to just cover this insolvency. So that should be a driver of trying to bring both parties together to deal with this issue in Congress. If you deal with it now, if you start making correct adjustments to the program, you could avoid having to deal with the crisis that is going to start hitting in 2031. And this notion that by not touching it, you're helping seniors is so misplaced, because you're really looking at very severe cuts kicking in if you don't do anything about it. So in fact, you're reforming Medicare to save health insurance for seniors over 65.
Yeah, you make an incredibly important point. Our politicians seem to think that nothing can get done in Washington without a crisis, and so basically they let the car go off the road, create the crisis, and then before they deal with anything. But some people think that this could be just paid for out of general funds, and CED's work has proven that that's not possible. So the reforms are necessary, and if not, then these cuts are draconian. And so what happens in a cut? I mean, so you're a senior, you're dependent on Medicare now, and it gets cut. Does that mean you don't get care?
Well, it either means you don't get care, or it means we kick in more general revenue from the budget, and which means you're increasing your deficits and you're increasing your debt, and you are putting the nation on a fiscal cliff that could end in a real debt crisis.
Yeah, devaluation of the dollar, the whole thing, and it's just not something that we consider, because we've just been blessed by a growing, healthy economy, the strongest in the world, and lots of money, and it's just viewed as being a bottomless pit of money, and it's not. I think that's your point here, and so there must be some serious action taken.
And one data point that's very important, which also equates this with national security: Medicare is costing us in FY 2023 $820 billion. That is equal to our defense budget. But another important data point is that our debt servicing of our $33 trillion debt is costing over $800 billion. And we are crowding out what we can actually spend without totally exploding further on a yearly basis our deficits and our debt. We're crowding it out with our debt servicing. We're crowding it out with a healthcare policies and a Medicare program that's exploding, and we're crowding it out. And you also have the demands of national security, which is very difficult to challenge right now, as the U.S. is involved in two wars in the world, one in Europe with an ally in Europe that had been invaded by Russia, and of course in the Middle East, where Israel is at war with Hamas.
We're discussing the history and the objectives of Medicare. Next, we're going to discuss potential changes to the system and what would be required to improve it. We'll take a short break and be right back.
What does the future of work mean for your employees? How will your company navigate ESG? Will there be a global recession? At the Conference Board, our experts translate the latest research and economic analysis into insights and real-time problem solving for your organization. Membership at the Conference Board provides your team with an assortment of knowledge from economics, marketing and communications, ESG, public policy, and human capital. As a member, you'll have access to our center experts, member-exclusive events, data and benchmarking tools, and peer sharing that will help you understand the present and shape the future. Consider becoming a Conference Board member today by visiting www.conference-board.org.
Welcome back to CEO Perspectives. I'm your host, Steve Odland, and I'm joined today by Dr. Lori Esposito Murray, who's the president of the Committee for Economic Development, which is the public policy center of the Conference Board. Okay, so Lori, we also have to talk about PPACA, or some people call it ACA, some people call it Obamacare, but this whole healthcare reform that was put into place about a decade ago and its impact on Medicare. Can you just give us a brief tutorial on that?
Okay, so just briefly, Steve, what happened with the Affordable Care Act and the Medicare program is that the Affordable Care Act actually eliminated the coinsurance and the Part B deductibles for certain preventive care services. And by doing that, it actually, with the goal of providing more preventive care, of hopefully reducing the cost of the Medicare program, it in fact has increased the cost, at least in the short term, of the Medicare program by providing even further benefits on top of the expanding benefits that have been happening over the years.
Yeah. So basically, it was supposed to cut costs, and it was supposed to expand, what it provided, but in fact, it raised costs. So exactly the opposite of the objectives that were set out.
And one of the problems is you're dealing with a demographic problem that is increasing. We're already at 66 million people who are using Medicare. Is increasing the number very rapidly as population gets older. And the way the program is structured and the way our healthcare programs are structured, the costs are rising rapidly, combined with inflation. And so you're seeing this while you're trying to do, all good intentions and preventive care to try and keep people healthy. You're actually hitting up against both the demographics and cost increases.
Yeah, but the frustrating part of this, your demographic point, is that there's no mystery in this. Everybody who's in this demographic has already been born. They're you know who they are. They're sitting out there, and you can count them. So it's just a matter of how long they'll live. So this is just really frustrating that our government hasn't been more proactive on this.
Well, to your point about it being the third rail, I mean, one of the most, saddest moments in the State of the Union address was when both sides agreed and applauded the fact that we wouldn't touch Social Security and we wouldn't touch Medicare. Yeah,
thereby ensuring we're going to have deficits as far as the eye can see. But so let's go back to what. When Medicare was put into place, I think the life expectancy was around 65, which is the retirement age and when it kicked in. Today, the life expectancy is significantly higher. It's in the 80s. So, there just seems to be some obvious things you could do to Medicare to revise it, but also to make it more sustainable.
So one of the key things, obviously, and CED has been calling for this for a number of years, and it's market-based. You put consumer choice into healthcare. You let market forces work so that the beneficiaries can choose, on the basis of quality, on price, among private plans, and they compete among each other, and that will help drive costs down as you're trying to appeal to beneficiaries. And so put the market back into healthcare and put consumer choice back into healthcare. And you've seen that with Medicare Advantage, where the more choice consumers had, you could see them making smart choices. And so that's number one. But the first thing we really need to to help bend this cost curve. And then Medicare Advantage itself, the second important proposal in terms of trying to bring costs down is to remove these price benchmarks that are based on fee for service. Medicare is based on a fee for service medicine, and that keeps it inflation prone. It keeps costs up. You need to switch and start with Medicare Advantage by removing the benchmarks based on fee for service and put competition back into those programs. They can serve as basically a test group for how you can do this in terms of reforming Medicare and bending the cost curve overall. And the third thing we should be looking at is raising, to your point about raising the age of eligibility, looking at that very seriously and incorporating that into the program, which it is being looked at and it is being adjusted or considered to be adjusted. And that would help really save money over the long term. Those are the top three.
If they made it any more complex, it would scare everybody away. But let's go to the market, the market competition thing. So is there competition in C&D? In other words, the Medicare Advantage, the privately funded parts?
Yes, there is. And so that it does serve, and it is working, and more people are actually joining Medicare Advantage, which is proving that putting in market-based reform, putting in a market-based program in terms of Medicare Advantage, it is appealing. It's allowing people choice. Our consumers are clearly smart. I mean, I know you and I are both challenged by this, but
well, I am.
But we are allowed the ability to actually have transparency, to pick our providers. There are problems with the program. It's regionally available in some places more than others. It's confusing, but nonetheless, it is, even with those disadvantages, it is growing and surprising people about how attractive it is. Surprising.
When you talk about adding competition, to Medicare, you're talking about parts A and B, then.
Yes.
Okay. And parts A and B are really controlled by the government. I mean, and they set the pricing, the reimbursement rates, and all of that. So setting competition means really privatizing it, I guess, would be one way to think about it, right?
Right. And reducing the role of government, which, if you look back at the beginning of the program and the goals of the program, to your initial question, the role of government in terms of its impact on healthcare pricing was supposed to be, and in terms of affecting the market, was supposed to be de minimis. It was not. It has grown over time, but one of the original goals was to have a health insurance program for seniors, but not one that was overly government controlled.
Right, and in fact, it's 100% government controlled. But a big problem here is reimbursements too. So if a doctor says, well, it costs me $200 to do XYZ procedure, Medicare says, well, we'll only pay $100. So the doctors say, well, I'm going to lose $100 on that procedure, and so therefore I'm not going to take Medicare patients. So you see a lot of the best doctors just not accepting patients, and so it gets whittled down, and the quality of care is diminished, and so forth. So there's I mean, this is far too complex to go into in a short podcast, but there's a whole bunch here where, and a lot of people say, privatization, that's a bad thing. But in fact, what you're saying is allow the markets to work, allow the competition then to drive the costs down, allow there to be variations in what's offered. Why should men have to have, maternity care, for example? And that sounds silly, but these policies are required. This is the policy period, regardless of age, gender, or any other variation. So you're not allowing people to buy what they need, like we would when we go to a store. So all of these things are what are behind this whole market-based definition, right?
Right. Exactly.
Okay, so the market-based thing is one piece of it. The other piece of it is access, okay, which is a key one of your points. Tell us more about that.
Well, so particularly if you're looking at Medicare Advantage, which is a perfect example, it is not universally nationwide available. It is available to different degrees and different levels by region. And so your ability to choose Medicare Advantage in part depends on where you live. And that in and of itself is one of the is a major roadblock to accessibility. And what you want in a national health insurance program for seniors is, number one, you want this program accessible, you want it affordable, and you want quality care.
Yeah, and some of the key areas of of the nation where they're lacking this is in the rural areas, or the lower less populated areas, or they have maybe one place to go, or maybe it's 50 or 60 miles away, which is really not good in the case of an emergency, or even in the case where you're trying to do proactive care. It's just too far, it's too much, it's too hard, and so you skip it. And so all of these things lead to bad outcomes from a health perspective.
Yeah, everything that you're seeing in terms of the problems in the healthcare system across the nation overall, and rural healthcare is a very important and significant problem in terms of accessibility. Everything that you're seeing on the national level in terms of healthcare is compounded when you're looking at healthcare for seniors, particularly since mobility for seniors is even more difficult than it is for the general population. So you're dealing with an older demographic with limited access to resources, and it just compounds the problem.
And Laura, your center has been talking to our elected officials for a very long time about this. And it's interesting, you've shared this before, that when you talk to people in Congress on both sides of the aisle, they acknowledge all of these issues, but they won't act on it. And so I think this kind of ends up where we started, which is there needs to be some political will here to take action, doesn't there?
Right. And what is the best creator of political will? It's a crisis. And what we want to avoid is the cliff, but 2031 is hovering right over us. And it's raising awareness. And as you know, Steve, that's what we're trying to do is raise awareness of the issue, raise awareness regarding the deadlines. And it's that type, in effect, the crisis, the insolvency of the Medicare Trust Fund should be leveraged to get solutions before we hit the wall and end up having to either increase the deficits and debt to deal with it, or cut the revenue available or the resources available to provide healthcare to seniors.
Yeah, and this conversation's been going on a long time. I remember when we were in our 20s, all of these things were being said at that point in time, and they still hadn't fixed it. And it's very easy for younger people to just ignore this and say, well, I'm not going to be 65 for a billion years, and so they'll fix it by then. But they haven't. And so this is an issue for people of all ages, not just people who are nearing or at retirement age. And I think, that's an important point too. Everybody needs to get involved. You need to tell your congressman, just act, get this fixed, stop fooling with this.
Well, and young people are paying payroll taxes. And they're also paying income tax. They're funding this. And if it all crashes and burns, all they've done is fund a broken program and not get any of the benefits.
Yeah, that's incentive as well. Lori, thanks for being with us today.
Well, thanks, Steve. An important conversation. I appreciate being asked to join you.
And thanks to all of you for listening in to CEO Perspectives. Every week, I'll be joined by a prominent thought leader to provide insights on the issues of our time. We'll cover the leading topics in economics, public policy, ESG, and more. Please share CEO Perspectives with your colleagues, with your friends, with anybody who can spell Medicare. I know they're going to want to listen. I'm Steve Odland, and this series has been brought to you by the Conference Board.
You have been listening to CEO Perspectives, a podcast by the Conference Board.